Glomerulotubular balance is the ability of the tubules to increase reabsorption in response to an increased tubular load. When the GFR increases, tubular reabsorption also increases proportionally. Glomerulotubular balance is most effective in the proximal tubules and loop of Henle, but less so in the more distal segments. Several factors affect the rate of tubular fluid reabsorption, significantly influencing the rate of fluid volume excretion, or urine output. Osmotic diuresis, seen in conditions like diabetes mellitus, occurs when non-reabsorbed substances like glucose, sucrose, mannitol, or urea pass through the tubules, carrying a large portion of water with them. An increase in plasma colloid osmotic pressure decreases fluid excretion due to both a decrease in GFR and an increase in tubular reabsorption. Sympathetic stimulation constricts afferent arterioles via beta-1 receptors, decreasing glomerular pressure and GFR. It also reduces peritubular capillary pressure, increasing tubular reabsorption, and stimulates renin release. Normally, changes in arterial pressure cause only slight changes in diuresis and natriuresis due to intact renal autoregulation. However, impaired autoregulation can lead to a marked increase in sodium and water excretion. This effect is due to increased arterial pressure, which raises glomerular pressure, increasing GFR, and also increases peritubular capillary pressure, decreasing tubular reabsorption. Hormonal control is vital. ADH increases water permeability in distal tubules and collecting ducts, acutely decreasing urinary volume. Aldosterone increases sodium reabsorption and potassium secretion in the cortical collecting tubule. Angiotensin II stimulates aldosterone secretion, enhancing sodium and water reabsorption. It also constricts efferent arterioles, reducing peritubular capillary pressure, which increases water and electrolyte reabsorption. Efferent arterial constriction also decreases blood flow through the glomeruli, concentrating plasma proteins and increasing colloid osmotic pressure in peritubular capillaries. This further enhances reabsorption of water and salt. Angiotensin II may also directly increase sodium reabsorption in the distal tubules and proximal tubules by stimulating the NAKATP ACE pump and NAH exchange. Furthermore, angiotensin II causes mesangial cells to constrict, reducing the capillary filtration coefficient and overall GFR. Atrial natriuretic peptide, in contrast, inhibits sodium and water reabsorption, increasing urinary output. Parathyroid hormone increases calcium and magnesium reabsorption in the loop of Henle and distal tubule, while inhibiting phosphate reabsorption in the proximal tubule. Renal function tests help diagnose and monitor kidney diseases. Renal clearance is the volume of blood plasma cleared of a waste substance per minute, reflecting filtration, secretion, and reabsorption. A substance used to measure clearance must be freely filtered, neither reabsorbed nor secreted, not metabolized or stored in the kidney, non-toxic, and not affect GFR. Examples include inulin, creatinine, and PAH. Clearance is practically assessed by sampling blood and urine. Using the formula C equals UV/P, where U is urine concentration, V is urine output rate, and P is plasma concentration, we can calculate renal clearance. For inulin, GFR is equal to the renal clearance. In clinical practice, GFR is often estimated from endogenous creatinine excretion, which is an easier procedure. PAH clearance measures renal plasma flow. PAH is completely cleared from the plasma by a single passage through the kidney. Clearance equals renal plasma flow, when a substance is completely cleared and excreted in the urine. Renal blood flow can be calculated from renal plasma flow and hematocrit. GFR is measured indirectly by calculating the clearance of a glomerular marker like inulin. Autoregulation of GFR and renal blood flow are intrinsic mechanisms that maintain these parameters constant despite changes in arterial pressure, typically between 80 to 200 millimeters of mercury. The stability of GFR and renal blood flow is essential to prevent excessive loss of solutes and water or insufficient excretion of waste products. These negative feedback mechanisms include tubuloglomerular feedback and the myogenic mechanism. The tubuloglomerular feedback mechanism operates through the juxtaglomerular complex and includes afferent arteriolar vasodilator and vasoconstrictor feedback. A low GFR decreases tubular fluid flow and Na and Cl concentrations at the macula densa. This signals the juxtaglomerular cells to dilate the afferent arteriole, increasing GFR. Conversely, a high GFR leads to constriction. The efferent arteriolar vasoconstrictor feedback mechanism is activated by low Na and Cl ions at the macula densa, causing JG cells to release renin. This leads to the formation of angiotensin II, which constricts efferent arterioles. Efferent arteriole constriction raises glomerular pressure, returning GFR to normal. Renin release is increased by decreased renal perfusion pressure, decreased renal flow, or stimulation of renal nerves. The myogenic mechanism stabilizes GFR based on the muscle's tendency to contract when stretched. Increased arterial pressure stretches the arteriole wall, causing contraction and decreasing renal blood flow and GFR.